Bismillahirrahmanirrahim. Assalamu alaikum and good morning. In today's core urology lecture, we will be discussing about male-related infertility. I am Dr. Hafiz Ahmadullah. The session will be moderated by Dr. Faisal Qurashi. Starting with the anatomy and physiology of male reproductive system, as we all know, it consists of testes, epididymis, vas deferens, seminal vesicles, prostate gland, bulbourethral glands, and penis, as shown in the image. The functions of male reproductive system include spermatogenesis as well as hormone production. Testes, which tunica albuginea. Internal structures include seminiferous tubules, and the blood supply are the direct branch of aorta and drains via testicular vein on left side into the directly into the IVC. The nerve supply arises from thoracolumbar spine, which is of sympathetic origin. So usually in seminiferous tubules, but their maturation and transport occurs in cases in epididymis. The process of spermatogenesis, as Dr. Faisal said, starts in seminiferous tubules, and it consists of 3 phases, including spermatogonial phase, followed by a meiotic phase, and then. Can anyone tell
in the body? Dr. Munazza? So the PSA normal function is to liquefy the semen. There's a protein in the semen which is known as coagulum, which results in liquefaction of the semen, so that it can be the sperms can be transported to fallopian tube and ultimately to the egg for fertilization.
Penis consists of 3 columns, 2 of and 1 of corpus spongiosum, which surrounds the penile blood supply or penile deep penile arteries arise from the artery, and the innervation is of parasympathetic and sympathetic origin. Spine of S2 to S4 level, and it causes erection of. And another pathway is as the nitric oxide that is released by neurons activates guanylate cyclase, which converts GTP into cGMP, which causes smooth muscle relaxation and venous occlusion, causing rigidity of the penis. The detumescence occurs as the cGMP is converted into GMP by phosphodiesterase. Ejaculation is divided into 2 phases, including emission, which is controlled by sympathetic origin, and expulsion, which is controlled by somatic nerves. Emission is release of semen into the posterior urethra, and expulsion is release of semen out of the urethra. Retrograde ejaculation occurs when there is failure of bladder neck closure. So the sperm flows from the seminiferous tubules through straight tubules into ready testes and then into epididymis, vas deferens, and ejaculatory duct, and then into urethra to the exterior. Infertility is defined as the inability of a sexually active non-contraceptive couple to achieve spontaneous pregnancy within 12 months It is classified into primary and secondary infertility, and then further can be classified into idiopathic and unexplained infertility. The primary infertility refers to couples that have never had a child and cannot achieve pregnancy after at least 12 consecutive months of having sex without using birth control methods. Secondary infertility refers to infertile couples who have been able to achieve pregnancy at least once before with the same or different sexual partner. Unexplained infertility or infertility of unknown origin is with normal sperm parameters and partner evaluation, and it consists of 20 to 30% of couples that visit a urologist or that visit a doctor with the complaint of infertility. In idiopathic infertility, when no male associated factor is found to explain the underlying impairment of sperm parameters. So the difference between unexplained and idiopathic infertility is that in unexplained infertility, the semen parameters will be normal, while in idiopathic male infertility, the semen parameters will be abnormal, but there will be no cause identified in both. Idiopathic infertility consists of about 30 to 40% of cases, and semen analysis may reveal pathological finding, but there is no previous history of disease affecting fertility, and normal findings on physical examination and normal endocrine lab testing. It previously it was thought that it is idiopathic, but now it is considered that it may be associated with previously unidentified endocrine disruptions as a result of environmental pollution and generation of reactive oxygen species, sperm DNA damage, or genetic and epigenetic abnormalities. So, male factor infertility can be identified in about 50% of infertile couple, usually together with abnormal semen parameters, and a pure male factor infertility can be identified in about 20% of infertile couples. Several risk factors such as genetic factors, urogenital abnormalities, or endocrine hormonal disorders or malignant diseases and gonadotoxic treatments can cause male infertility. Causes can be divided into pre-testicular, testicular, and post-testicular causes. The pre-testicular causes consist of acquired or genetic endocrinopathies and disorders of production or secretion of gonadotropin-releasing hormone, disorders of pituitary hormones, including luteinizing follicle-stimulating hormone or androgen functions. And testicular causes includes varicocele, cryptorchidism or undescended testes, and tumors of the testes, and exposure to gonadotoxins or genetic abnormalities of testes. Post-testicular causes include obstruction of obstruction at any level of any level of, including epididymis or seminal vesicle or ejaculatory duct obstruction. Also includes immobility and disorders of ejaculation. The infertility can also be caused by general general or systemic diseases, including diabetes or hypertension, and then the cause can be idiopathic. So moving to the evaluation, focused history, after which we will do a physical examination and then initial lab testings, followed by imaging or testicular biopsy and genetic analysis. So the history includes fertility history, sexual, medical, surgical history, developmental and childhood history, and of marriage and infertility, along with history of and previous fertility investigations and treatments. Sexual history includes asking about frequency of intercourse, libido, covered diseases, along with history of any medication intake and their duration of use, history of any urinary tract infections, and history of sexually transmitted disease. Patients with past surgical history, including vasectomy or testicular surgery, such as varicocelectomy or hydrocelectomy, or with history of inguinal hernia surgery, or any history of sympathectomy, prostatectomy, or bladder neck surgeries, or urethral stricture treatments, or penile surgeries for hypospadias and epispadias. In developmental and childhood history, a history of mumps or other viral illnesses will be asked any history of scrotal injury or testicular torsion and treatment of testicular maldescent or undescended testes and the age at the treatment and puberty onset of puberty and sexual secondary sexual characteristics or development of secondary sexual characteristics. Occupational and environmental history includes asking about exposure to heat and exposure to toxins, exposure to carcinogenic dyes or tannins, which can cause oxidative stress, DNA damage, and disruptions to the hypothalamic pituitary gonadal axis. History of substance abuse. It can cause erectile dysfunction, direct damage to the sperm DNA, semen volume, and pH. Family history includes history of infertility, history of recurrent pregnancy losses, congenital birth defects, history of undescended testes or metabolic syndrome and endocrine disorders. Typical findings from the history of a patient with infertility includes presence or absence of undescended testes, history of any testicular torsion and trauma, and history of genitourinary infections, and exposure to environmental toxins, gonadotoxic medications, including anabolic drugs or chemotherapeutic agents, and exposure to radiation or cytotoxic agents. So, anybody can anybody identify the instrument?
Sakaula, can you identify what is it and how we can use it and where? Dr. Fayaz? Adnan? Basically, it is a Prader oximeter with which we can compare the normal testicular volume, which is basically normal from 15 ml to 30 ml. So if it is less than 12 ml, then it is considered as having a testicular, the patient is having a testicular atrophy.
So after the detailed and focused history, moving on to the physical examination, a focused physical examination includes presence of secondary sexual characteristics, the use of Prader's orchidometer to detect the size or volume of the testes, and the palpation of the testes to sense the texture and consistency of the testes, and the palpation of the testes to detect the presence of vas difference, fullness of epididymis, or presence of a varicocele, and palpable abnormalities of testes, epididymis, and vas difference, including any epididymal cysts or testicular mass, abnormality of penis, including phimosis, fibrotic nodules, or epispadias or hypospadias. And general physical examination can reveal abnormal body hair distribution and gynecomastia. The characteristics suggestive of testicular deficiency include abnormal secondary sexual characteristics, abnormal testicular volume and or consistency, testicular masses which are suggestive of potential cancers, absence of testes unilaterally or bilaterally, presence of gynecomastia or presence of a varicocele. Moving on to the laboratory investigations, first of all, we will do semen analysis and along with endocrine evaluation. So, can anybody has idea about Tiger-Bur's strict criteria? What is the criteria used for? So the Tiger bird strict criteria is used in semen analysis to classify or to assess the morphology of sperms. We will be discussing about it in detail. Uh, in semen analysis, when we are observing the semen's sperms, the Tiger bird strict criteria includes the identification of head, midpiece, tail, and cytoplasmic droplets and vacuoles of the sperm. And the strict criteria says that head should be smooth and perfectly oval, 4 to 6 micrometer in length into 2.4 into 3.5 micrometer in width. It should be well defined. It should have a well defined acrosome which should cover 40 to 70% of sperm head. And the midpiece should not have any defects. It should be slender, regular, and width should be less than 1 micrometer, and the length should be 1.5 times the head size. The tail should reveal no tail defects and should be of uniform size and 10 times the head length, and that is 45 micrometer long. There should be no cytoplasmic droplets, and vacuoles that are allowed are up to 4. The borderline morphology is considered as abnormal. So the 6th edition of the WHO Manual for Examination and Processing of Human Semen includes semen examination, sperm preparation and cryopreservation, and quality assessment and quality control of the semen. The procedure for semen examination are divided into basic examinations, extended examinations, and then advanced examinations. The basic semen examinations include assessment of sperm numbers, assessment of sperm motility, and then dividing into fast progressively motile or slow progressively motile, and then non-progressively motile and immotile sperms, and the assessment of sperm morphology by using Tiger-Berg strict criteria as we discussed, and the assessment of vitality of the sperm, that is if the sperm are alive or dead, and if the vitality of sperm is assessed if more than 60% of spermatozoa are immotile, and it is done by the staining that is named as eosin nigrosin stain.
So usually to differentiate between the dead sperm and immotile sperm, the viability assay is usually done, in which eosin nigrosin staining is done. The alive sperm usually resists the staining, so it will be shown as white on microscopic examination, while the dead sperm usually seen red on the microscopic examination. So if we have to differentiate between the dead sperm and whether they are dead or immotile, usually this staining is or viability assay is usually done. So how we will differentiate between whether between us sperm and the WBCs? Can anybody tell? So usually a mature sperm on the microscope, as we have discussed earlier, it will have a definitive acrosome and the tail piece, the head piece, and the WBCs or the neutrophils usually have the polymorphic nucleus. So this can be differentiated on the basis of these findings.
The extended examinations of semen includes detection of leukocytes and markers of genital tract inflammation and sperm autoantibodies, and the indices of multiple sperm defect. The indices of multiple sperm defects include teratozoospermia index or multiple anomalies index or sperm deformity index. In advanced testing of semen, we detect the semen biochemistry, sperm DNA fragmentation, and there are methods to detect sperm aneuploidy. It is needed in men belonging to couples with recurrent pregnancy loss and men with unexplained infertility, and increased sperm DNA damage is associated with pregnancy failure and recurrent pregnancy loss. So the picture shows lower reference limits of semen parameters. Semen volume should be more than 1.5 ml, and the sperm number should be more than 39 million per ejaculate. Progressively motile sperms should be more than 32%. Non-progressive motile should be around 1%, and more than 58 to 60% sperms should be viable. normal forms should be more than or equal to 4%, and leukocytes should be within the range of 1 to 2 into 10 raised to power 6 per ml. The pH of the semen should be more than 7.2, and peroxidase positive leukocyte should be less than 1. To detect the anti-sperm antibodies, there are mainly two tests. One is mixed antiglobulin reaction test, and other is immunobead test. The MAR, or mixed antiglobulin reaction test, detects motile spermatozoa with bound particles. To carry MAR, a semen sample is collected. The sample is mixed with latex beads coated with antibodies, either IgG or IgA, and the mixture is examined under a microscope to see if sperm are attached to the beads. If sperms are attached to the beads, it indicates the presence of antibodies on the sperm surface. Immunobead test is carried using same method as MAR, but in this, the difference is it uses polyacrylamide beads coated with antibodies against human immunoglobulins. So if semen analysis is normal according to WHO criteria, a single test is sufficient. If results are abnormal on at least two tests, further andrological investigation is indicated. The prerequisites for semen analysis include abstinence for about 2 to 3 days, but not more than 5 days, avoidance of substances including alcohol, tobacco, and recreational drugs, and any medications and supplements that can affect sperms. In patients who cannot come to the lab to deliver the sample, within the premises of the lab, special condoms can be used to collect sperm or collect semen after sexual intercourse. The collected sample should be clean, and liquefaction should be done at body temperature for around 30 to 60 minutes. Accessory gland functions can be assessed in semen analysis. Seminal zinc should be more than 2.4 micromole per ejaculate. Seminal fructose should be more than 13 micromole per ejaculate, and alpha glucosidase should be more than 20 million unit per ejaculate. So the picture shows comparison of obstructive azoospermia with non-obstructive azoospermia. The obstructive azoospermia occurs due to the blockage in the reproductive tract, and it prevents sperm release. And non-obstructive azoospermia is due to testicular failure to produce sperms. In obstructive azoospermia, the testicular size is usually normal, while in non-obstructive azoospermia, the testes are often small or can be soft or can be absent. FSH levels are usually normal or mildly elevated in obstructive azoospermia, while in non-obstructive azoospermia, FSH is usually elevated. LH is usually normal in obstructive azoospermia, while in non-obstructive azoospermia, it may be low. Testosterone is also normal in obstructive azoospermia, while in non-obstructive azoospermia, especially in hypogonadism, it is usually low. Semen volume. If the ejaculatory duct obstruction is present, then semen volume will be less, or semen may be absent in obstructive azoospermia, while in non-obstructive azoospermia, it is semen will be present. Semen pH can be acidic in obstructive azoospermia with ejaculatory duct obstruction, and in non-obstructive azoospermia, pH will be normal. Epididymis or vas difference on examination can be absent or give a sensation of fullness or firm in obstructive azoospermia, while in non-obstructive azoospermia, the testes are usually small volume and of heterogeneous texture. Scrotal ultrasound may reveal dilated epididymis, or congested seminal vesicles may be seen in obstructive azoospermia, while in non-obstructive azoospermia, it is usually normal. So abnormalities found on semen analysis can be divided into oligozoospermia, which is sperm count less than 16 million sperms per ml, actinozoospermia, which is less than 32% of progressive motile sperms, and teratozoospermia, which is less than 4% of the normal forms. Odd syndrome includes all the three, including oligo, asteno, and teratozoospermia. Azoospermia is complete absence of spermatozoa in semen, and it can be further divided into obstructive azoospermia and non-obstructive azoospermia. Cryptozoospermia is extremely low sperm count, where sperms are present in ejaculate, but only detectable after extensive examination, including often after centrifugation.
So when there is a cryptozoospermia or the low sperm count in the semen, so always rule out the retrograde ejaculation. So can anybody tell how we will rule out retrograde ejaculation in a patient with cryptozoospermia? So the post-coital urine analysis would be the best in patient having cryptozoospermia. So usually we have to ask the patient to have potassium citrate before the analysis to assess, to make the urine more alkaline, because sperm cannot be survive in the acidic environment of the urine.
Advanced examinations include assessment of reactive oxygen species and oxidative stress, which can lead to sperm DNA damage and poorer DNA integrity. It is associated with poor lifestyle, environmental exposure, chronic infections, and varicocele. Antioxidant regimes and lifestyle interventions may reduce the risk of DNA fragmentation and improve sperm quality. The DNA fragmentation can be measured by different tests. Some of most commonly used tests are SCSA, that is sperm chromatin structure assay, or sperm chromatin dispersion test. And in SCSA, the number of cells with DNA damage is indicated by DNA fragmentation index. The DNA fragmentation index of 25% is associated with reduced pregnancy rates via natural contraception or intrauterine insemination of sperm. And DFI of more than 50% is associated with poor outcomes from in vitro fertilization. After semen analysis or with semen analysis, hormonal profile is usually asked, which includes FSH, LH, testosterone, prolactin, and TSH levels. The FSH levels usually above 7.6 million international unit per ml are considered abnormal, while some labs gave the reference limit between 12 to 15 million international units. LH is usually ordered. Testosterone levels greater than 298 nanogram per deciliter should be there. Prolactin is associated with erectile dysfunction, and TSH can give the diagnosis of hypo or hyperthyroidism. So in testicular failure or primary hypogonadism, FSH and LH will be raised and testosterone will be decreased. In failure of spermatogenesis, FSH will be increased while LH and testosterone will be normal. And in secondary hypogonadism or hypogonadotrophic hypogonadism, FSH, LH, and testosterone will all be decreased. Imaging techniques can be diagnostic or therapeutic. The diagnostic techniques identify the possible causes of infertility, while therapeutic techniques may give the chance of image-guided sperm aspiration. Main modalities are ultrasound, MRI, and invasive techniques such as venography and vasography. So ultrasound is the initial imaging investigation and aims to detect or evaluate the testicular morphology, patency of efferent ducts, prostatic anomalies, and erectile function assessment. The techniques include scrotal ultrasound and a transrectal ultrasound and beam mood and dynamic color Doppler ultrasound of penis. Scrotal ultrasound is the initial evaluation of scrotums. It detects the testicular and peritesticular structures and their abnormalities, including varicocele and epididymal abnormalities. It shows secondary changes caused by distal genital duct obstruction. The probe used is of high frequency, that is 7 to 12 megahertz, and it is a linear array transducer. Position should be spine. The components of examination include delineation of anatomy. After that, a color Doppler and volume measurement of the testes. The volume is measured by multiplying length into height and width into 0.51. A total volume of both testes of 30 ml or a single testicular volume of 12 to 15 ml is generally considered normal. So the image shows in A, that is a normal testes, and the image B is the ultrasound image of a small testes. The A shows a normal echo texture and normal reflectivity of the testes, while in the smaller testes, we can identify the heterogeneous texture. So this is the ultrasound image of a heterogeneous testes with associated dilatation of reti testes, as shown with the small arrows, and dilated body of the epididymis, that is shown with the longer arrow. It is due to the long-standing obstruction. The first one, the A image, shows a scan of a small testes with a heterogeneous echo texture and a varicocele as marked by smaller arrows. In the second image, we can identify the focal dilatation of epididymis, showed by a larger arrow, secondary to a chronic obstruction, which can be due to a secondary infection, which can be secondary to an infection. So the first image shows the typical findings after a vasectomy has been done. And the second image shows the image of an undescended testes that is within a left groin, and it is of heterogeneous texture and a smaller volume. The first image shows the scrotal ultrasound of smaller testes, and the second image shows multiple reflective areas or mixed reflectivity demonstration of testes following infection that causes orchitis. So TRUS is used for imaging of prostate, seminal vesicles, vas deferens, ejaculatory duct, and it is modality of choice in obstructive azoospermia. Also, it can be therapeutic as it guides the prostatic cyst aspiration. The position should be left lateral decubitus, and probe used is high frequency endorectal transducer with a condom cover.
So when you are suspecting obstructive azoospermia in a patient, most probably secondary to ejaculatory duct obstruction, so TRUS is usually performed in transrectal ultrasound in an ejaculatory duct obstruction patient. Usually the seminal vesicle volume is greater than 1.5 ml. So if you found a greater dimension of the seminal vesicle, which is more than 1.5 ml, so usually aspiration is done. If it shows viable sperms, which is more than 3 or 4 per aspiration, so then you have to perform the definitive procedures, which is the ejaculatory duct obstruction, resection of the transurethral resection of the ejaculatory duct.
So these two images show the first shows the transrectal ultrasound of prostate gland cyst in the prostate gland with a diameter of 1 to 8 centimeter, and it is compatible with the cyst due to remaining of Mullerian ducts. The remains of Mullerian duct. The second one shows the congested seminal vesicles secondary to a distal obstruction of ejaculatory duct.
So in figure 1, we can appreciate that the seminal vesicle volume, seminal vesicle is distended. So the volume here probably more likely to be more than 1.5 ml. So here we can aspirate the sperm, the content of the seminal vesicle. If it shows that there are viable sperm in it, then there is a definitive cause, which is the ejaculatory duct obstruction. But if the volume is if there is high suspicion, risk of suspicion of obstructive azoospermia, and on transrectal ultrasound, the seminal vesicle volume is less than 1.5 ml, so there would be the obstruction other than the ejaculatory duct, that is the probably in the vas or epididymis. So you have to exclude and do other specific investigation, which we will discuss ahead.
For penile examination, a beam mode or brightness mode and a dynamic color Doppler ultrasound is performed. It evaluates the cause of erectile dysfunction, and physical causes include structural penile abnormalities or problems with arterial inflow, or problems with venous occlusive mechanisms. B-mode ultrasounds is used to detect structural abnormalities, while color Doppler is used to detect for detection of vascular causes of erectile dysfunction. So the color Doppler is usually performed after intracavernosal injection of prostaglandin E1, followed by measurement of peak systolic and end-diastolic velocities of cavernosal arteries. So normal peak systolic velocity of cavernosal artery should be more than 30 centimeter per second, while end-diastolic velocity should be less than 5 centimeter per second, and the resistive index should be more than 0.85. So after the injection of prostaglandin E1 at 5 minutes, 10 minutes, 15 and 20 minutes, the color Doppler is done to detect peak systolic and end-diastolic velocities, and a maximum erection is expected by 10 to 15 minutes. The PSV less than 25 centimeter per second represents arterial insufficiency, and diastolic velocity more than 5 centimeter per second represents vasogenic erectile dysfunction or veno-occlusive disease. Resistive index of less than 0.75 shows venous leak or impaired resistance. Normal PSV along with high end-diastolic velocity usually represents venous leak, while a low peak systolic velocity and a low end-diastolic velocity usually represents arteriogenic cause of erectile dysfunction. The color Doppler imaging of on the image A on right side of the screen is of varicocele, and on left side of the screen is of testicular mass. MRI is used for the detection and characterization of prostatic cysts that are detected on transrectal ultrasound, and also for the evaluation of vas difference, seminal vesicle, and ejaculatory ducts. The protocol for imaging is triplanar T2 weighted spin echo along with long repetition time and along with a long echo time. T1 weighted turbo spin echo is that is short repetition time and short echo time. The triplanar high resolution images of 3 to 4 mm slice thickness are taken with a small field of view, and a pelvic body coil is generally used, although some centers use endorectal coils. The MRI image of a normal prostate, the MRI image of a prostatic cyst that is pointed out by an arrow.
Thank you.
Just a video clip of the point earlier mentioned, and that was about the movement of or the forward propulsion of the sperm. So normally we think that a sperm is actually a swimming kind of a sperm. It doesn't swim, it rather spins. So it's a spinner, not a swimmer. Just a video clip how to imagine the sperm actually moves and moves into the ovum. Okay. So this is a high speed photography. So as you can see that the red one is the headpiece and the blue one is the tailpiece. So the movement is something very different. It is like screwing in rather than a movement like a spin, like a swimmer, which means that the head is still and the tail is moving. Here the head is also moving, the tail is also moving, but the tail is moving in many different directions. So this is the screwing movement. So this is how the sperm actually propels forward antigradally towards the ovum, crossing the white line membrane and pierces through the structures and then puts all the things into the nucleus. So there is one thing at the top of the head also, which is not shown here, and that is acrosomal cap. And that acrosomal cap actually facilitates its movement and penetration. So that's it. Thank you very much.